The brain is the most complex organ in the human body. We seek to guide you through the good, the bad, and the ugly. Join us in discovering the secrets of the human mind as we present to you NeuroBiology Made Easy.
Welcome to the NeuroBiology Made Easy podcast, where we discuss current neurobiology and science-based tools to start to understand some of biology's biggest challenges, one topic at a time. I'm Aidan Becken, and I'm a senior biology student at St. John's University. Today, I am joined by three of my fellow colleagues, Senior Anna Wolf, Junior Ben Karst, and Junior Nathan Ringsman. Collectively, our discussion will be surrounding the topic of insomnia. Now, we have all had an experience of a restless night where we find ourselves tossing and turning and never seeming to reach a productive sleep state. Diagnosed chronic insomnia is more than the odd night of missed sleep. Rather, chronic insomnia can be diagnosed upon an individual having difficulty falling or staying asleep for at least 3 days a week for over 3 months. This is a massive chronic health issue in the United States, as over 3 million Americans cope with symptoms of insomnia in a given year. And odds are, this population of individuals includes someone you know well, whether you're directly aware of it or not. Our goal for today, then, is simple. We will aim to gather high-level, modern information surrounding insomnia and present it in a way that is easy to understand and maybe even personally applicable, so that the cutting-edge science we hope to get into can be effectively understood by you all, the general public. Today's panel is a collection of experts on specific facets of the broad domain that is insomnia. We will first hear from Ben, our expert on what insomnia is on a biological lens. Ben will also begin our exploration of what might be causing the symptoms of insomnia to arise. We will then turn to Anna, as she will touch on EEGs, electroencephalograms, a critical component for our understanding of insomnia. We will then hear from Nathan as he explores some of the modern applications we can hope to apply to take someone with chronic insomnia and provide them the treatment they need to get them back to sleeping through the night. I must preface that this discussion is far from exhaustive, as the current literature on insomnia abounds. There also exist complications with some of the data that currently presides in our most prominent journals, a problem I will be sure to touch on as we wrap up. But enough from me, let's turn to our experts. Ben, thank you very much for being here.
It's an honor to be on the show with you, Aidan.
Yes, no, thank you very much. Before we get into what insomnia really is, I think it might be valuable for us to discuss what a normal night of sleep might look like. Could you get into a little bit of that?
Absolutely. A normal night of sleep should be about 7 to 9 hours in the average person. This should be on a daily basis, fitting into your schedule. It should be at night, but it can vary depending on your busy schedule. You should feel restful when you wake up, and this is on average for adults. It can vary in children as well.
Yes, and thank you for that intro. So then, let's dive into insomnia. What is insomnia?
Insomnia is a difficulty in falling asleep, maintaining sleep, and it is a difficulty in waking up before a healthy amount of sleep is reached. As you've mentioned earlier, this needs to occur at least 3 times per week for at least 3 months or longer. And the person who is experiencing insomnia needs to have had an adequate opportunity to receive the sleep necessary. And they need to have some daytime suffering or symptoms that are impairing their daily life. Insomnia is prevalent in about 10% of adults and can vary based on your age or gender. It is actually the second most common mental disorder. It follows a combination of the most common anxiety disorders, and it is immediately followed by major depression. Insomnia also coincides with many of these disorders, and just to make your life a little bit more miserable. Insomnia can cause you to feel mentally fatigued or impaired, but it doesn't necessarily cause you to feel sleepy or drowsy. You'll just be at a state of discontent throughout the day. It has many symptoms, a few of which that I'm interested in are neuroticism, which is the experience of feeling negative emotions like anger or depression. Hyperarousal is a sudden burst of energy, usually prevalent in post-traumatic stress disorder. And rumination, which is the constant dwelling on negative events or thoughts that may occur in your life. Your brain activity generally stays intact, and your ability to comprehend topics or have reflexes is not impaired. But there have been conflicting evidence regarding your ability to maintain memory from the preceding day or from overnight learning. Basically, insomnia is a relatively common mental disorder that can impair your sleep, but also can impair your mindset or your daytime functioning.
Thank you very much for some of that foundational knowledge, Ben. Could you just maybe expand a little bit more generally on where this insomnia comes from on that biological level?
Absolutely. There haven't been any definitive causes, as there has not been enough adequate data collected to draw conclusions. However, some of the big observations that have been made that can relate to insomnia are age, gender, stress, and other environmental factors, as well as genetics. So first, let's get into gender. Insomnia is much more common in women than men. There have been observable differences in the brain structure and function in women relating to how they handle stress as opposed to men. Women are also more likely to acquire PTSD. Animal studies have shown women also handle emotional situations more strongly than men. Mm-hmm. Age is a contributing factor as well. Adolescents have more trouble maintaining sleep, whereas young adults have issues with falling asleep, and elders and senior citizens have a lot of trouble with waking up too early. Insomnia is actually the most common in women at the ages of puberty, occurring at about 28% of women. A group from the Sleep Research Society has actually done a study on whether insomnia occurs through family or if it is a environmentally based mental disorder. They collected a group of relatives, biological relatives, and they compared them to other biological relatives who either have or do not have insomnia. They found that 18% of people who are related to someone with insomnia have a chance of getting insomnia. Whereas if neither person has insomnia, then it's only about a 10% chance of either person acquiring it. Between siblings, you're actually 5 times more likely to acquire insomnia if your sibling has it, whereas if neither of you have it, it's only about 5%. And there is no significant changes between parents and children, though there is a significant change between spouses, being about twice as likely to acquire it if your spouse has insomnia, whereas if they do not. Lastly, stress and mental health issues is a major factor in insomnia. Another investigation by the Sleep Research Organization has shown that stress is actually extremely associated with insomnia. Sleep reactivity, or your attentive and alertness during sleep state, has been shown to be higher relative to your levels of insomnia as well. So the more intrusive thoughts during the nighttime, or the more alert you are at night, the higher risk you have of getting insomnia. They also touched on a lot of the previous topics that I mentioned. Notably, gender and age are really the only demographics that show any major effect towards insomnia, and depression is almost directly related.
Well, thank you very much for all of that information, Ben. We can see there's a lot of different avenues that can get us to insomnia, so it's a very complex thing and something that I'm glad we have that foundational knowledge for. So I think that turns us really well over to you, Anna, and some of the things that you're going to bring into our discussion today. Now that we have this general framework for what insomnia might be and what some of those causes might be, can you tell us some of the ways that we're able to currently diagnose that clinically?
Yeah, thanks for having me, Aiden. So we have some really interesting questions when it comes to diagnosing insomnia. So one of the things that's frequently used by physicians is the DSM-5 criteria. And so what that is basically is a format in which physicians are able to kind of see certain characteristics and certain things that people with insomnia should be having. So in terms of symptoms, kind of as Ben mentioned, some of the things that they look for are 3 months of symptoms in which you have issues falling asleep, staying asleep, or waking up more than intended. And so those are more on like a 3 days a week basis or more. But with that, in the DSM-5, it's not necessarily super clear always when somebody says that they're having like poor sleep and trying to say, okay, is this from insomnia or some other thing? So one of the things that they'll actually do is sleep studies. And so in these sleep studies, they monitor a wide variety of things. So they look at eye movement, heart rate, body movement, things like that. But one of the key things with that is brain activity. So typically that's the EEGs or encephalograms. So.
Yeah, right. And those all sound very interesting. But one of that thing you just mentioned at the end, the electroencephalogram EEG, I think some of our listeners back home might have a little bit of experience on what these might be, but I think they'd benefit a lot if you could dig in a little bit more of what these really are.
Yeah, so EEGs are pretty interesting. So what they do is they record your brain activity, and they do this by placing electrodes on your scalp. And so with that, they're getting data about what electrical things are happening in your brain on like a cortical level. So that just means that they're basically getting that outermost level of your brain and the activity that comes from that. And so obviously they've been used in a lot of these sleep studies when people are sleeping to kind of try to figure out what's happening in their brains. But they are used for other things too. And recently, a study by Maria Corsi Cabrera kind of delved into this idea of what's happening right before we go to sleep and right after we wake up, and looking at the brain activity with that. So one of the things that Maria and her team hypothesized is this idea that people who have insomnia may be having differences in how active their brains are when they're going to bed or waking up. And so they kind of hypothesized that these people with insomnia have this hyper-aroused state in which their brains aren't necessarily resetting or getting to a lower level of activity.
Yeah, the study that you mentioned is something I have a little bit of background on, and it's a very interesting study. Could you tell us a little bit more about what they ended up finding in their experiments?
Yeah, so in figures 2 and 3 of the study, they kind of set up a lot of the data that actually gives us some good conclusions. So what we find in that is that in people in the control groups who don't have insomnia, what we're finding is that their brain activity actually decreases in the morning relative to what it was the night before. So they look at the beta and gamma waves, which are kind of technical, but basically what it's getting at is that your activity in your brain is lower when you're waking up. But when you look at the insomnia control group, they are having pretty much the same level of activity that we see in the night and then in the morning. So this kind of poses some interesting questions when we look at, okay, so they have this extra like hyper-arousal in their brain. And so is this potentially why they say that they feel tired, even if during like a sleep study it doesn't show that they had bad sleep?
Right. No, yeah, this has some very interesting implications and possibilities when it comes to trying to understand really what is happening when someone has this insomnia disorder.
Yeah, it definitely does, because there's so much that we don't know still about some of the mechanisms behind it. So poses some interesting questions when it comes to trying to treat it.
Yes, and thank you very much, Anna, for all of that. That's very helpful for both myself and for, I'm sure, those back home. Before we turn to Nathan to hear a little bit more about some of our modern treatment protocols, I must bring up a recent 2016 study that, Anna, I'm sure you're well aware of, that gets into more depth about those EEGs, those electroencephalograms, and a problem that might actually be arising with that. Prior to this research, it was thought that when we had those EEGs recordings and placed those electrodes on your head like you mentioned, that EEG was collecting the sleep spindles that were representative of a patient's entire brain. And as it turns out, that's not necessarily always true. What this research team did is they took 5 adult male rats, anesthetized them so that they could do a surgical procedure and take one of those electrodes from a typical EEG that looks at the outside of your brain, and they put it deep into their brain, a structure called their hippocampus, to be able to measure if the sleep that the inside of your brain is having is actually synchronous at all times with the sleep that the outside, or you might have heard the cortex of your brain, is having. So once all of the electrodes were in place on these rats, both externally and internally, the research team compared what that cortex was, or how that cortex was sleeping versus how that hippocampus was sleeping. And you might recognize some of the sleep states shown on the figure that we're going to provide. You have your waking states, your slow wave sleep, your transition to REM, your REM state, which is your rapid eye movement. You might have heard about some of that. And the figure A gets into what we originally thought isn't always completely wrong. Sometimes the cortex reading and the internal hippocampus reading did say that your brain was in the same sleep state. And so that was good to know. But figure B really gets into the discovery of this paper, and where these two areas of sleep weren't actually sleeping synchronously, or they were in different stages of this sleep. And so why is this important to us? Let's put it in terms of a sleep study where, let's say, a patient gets a EEG recording of just externally, and we're able to record that they had a very great night's sleep, but the patient wakes up and they report, they think that they slept terribly, they don't feel great. Before, we would have had no idea what's going on here. None of our readings are really telling us anything. However, now that we have this knowledge that our brain actually might be sleeping region by region or piece by piece in our brain instead of as one entire brain, we're able to learn a little bit more about how our brain actually sleeps, which is super helpful for us as we try and figure out ways that we can combat insomnia going forward. Just very interesting stuff, and very happy that we were able to find this and be able to get ourselves on the right path for our insomnia studies.
Yeah, and just to add on to that a little bit, in recent years, and kind of partially because of this study, there's been some new developments technologically. So we've had some progress in looking at EEGs in combination with other types of measurements. So doing things like fMRI, where we can look deeper into the brain to try to see what's actually happening.
Right. Lots of exciting avenues going forward, and things that I'm sure we'll have to keep our eye on, and as new studies continue to come out. Well, thank you very much, Anna, for all of that. I'd like to take a quick moment to acknowledge one of our sponsors, the Shoe. Our topic we've been talking about, insomnia, it really deals with those of us who struggle to stay asleep at night, but there's also plenty of us, myself included, who really struggle to stay awake during the day. For those days of class when you just have to stay awake and keep going, go stop by the Shoe and get yourself a cup of alertness. Returning now to insomnia and over to our final panelist, Nathan, let's get into some of the things that we know about existing treatments and maybe some of those treatments that might be much newer. So, Nathan, thanks for being here with us.
Yeah, thanks again for having me. The first treatment that I'd like to discuss involves no outside medication. Cognitive behavioral therapy, or CBT for short, allows the individual to take control of their behaviors or their mood / negative thoughts and actions that generally keep you awake, either right before you fall asleep or while you're trying to fall asleep. Now, there are cognitive benefits to CBT as it teaches you to recognize and combat these negative feelings that keep you awake. And then besides the cognitive part, there's also a behavioral aspect where it teaches you your body's physical reactions and allows you to peacefully enter sleep throughout the night. So one strategy that CBT utilizes is sleep restriction, which short-term increases the body's sleep deprivation by not allowing any naps during the day and reducing time in bed overall. This sleep deprivation allows the individual to become more tired the next day. And so as they start to gradually increase in sleep quality, their time in bed will gradually increase as well. Another strategy of CBT seems a little paradoxical, but it is to remain passively awake. Now, lots of people with learned insomnia worry a lot that they aren't going to be able to fall asleep in general. Those with learned insomnia have lots of worries about being able to fall asleep in general. So this strategy aims to reduce that fear or worry by having them lay in bed and try and remain awake instead of fall asleep. Now, eventually this can help to reduce that cycle of worrying so much about falling asleep that you stay awake.
Yeah, those are very interesting concepts, and thank you for those being able to attack this insomnia without the actual use of any direct medications. Leading forward, however, I'm curious, do you have any treatments that are currently available that apply current medications?
Yeah, as for treatments regarding medications, there are many types of prescriptions available, and they all work a little bit differently. One of the most common, if not the most common, prescribed fix to insomnia is sleeping pills. Now, arguably, one of the most common sleeping pills is a brand called Ambien, and the active ingredient in that is called zolpidem. Now, Ambien is a central nervous system depressant, and it enhances the ability of GABA, which slows the brain's activity during the night. Now, Ambien has been shown to have promising results regarding sleep. However, there are serious side effects that make doctors not prescribe it for more than 3 to 4 weeks at a time. Some of these side effects include drowsiness during the day, as well as potential sleepwalking, sleep driving, and even sleep binge eating, which...
Yeah, the sleep driving one really gets me. That's pretty scary.
Yeah, they just wake up on the side of the road or like at a destination and they have no memory. And that's another side effect, memory loss. Now, as these side effects can be quite severe, they have been looking for potential alternatives for zolpidem or Ambien in general. And so current treatments such as benzodiazepines or other sedative prescriptions do not really properly address the sleep onset or sleep maintenance problems that insomnia produces. One potential answer was found or was researched in 2019 by Dr. Margaret Moline, in which a clinical trial looked at a drug called lemborexant in comparison to zolpidem extended release and a placebo control group. Lemborexant is a drug that does not work the same way as benzodiazepines or Ambien, and it is a dual orexin receptor antagonist. Now, orexin is a chemical in the brain that controls wakefulness, arousal, and even appetite. And so when these orexin receptors are blocked, it can help regulate the body's sleep and wake cycle. So in order to be a participant in this study, individuals had to be at least 55 years or older, and they had to fit the criteria of chronic insomnia as described by DSM, which I think you checked up on a little bit earlier. One figure from the study shows the distribution of the 1,006 total participants into each therapy group. And the participants that were screened were randomized in a double-blind experiment. So neither the researchers nor the participants knew what therapy group they were getting. Now, these therapy groups included 5 milligrams of lemborexant, 10 milligrams of lemborexant, 6.25 milligrams of zolpidem extended release, and just a plain old placebo. And they took these nightly for a total of 30 nights. Latency to persistent sleep, or LPS, which tells us how long it takes to fall asleep from lights out, was significantly decreased in the lemborexant groups, especially on nights 1 and 2, when compared to both the zolpidem extended release group and the placebo group. Additionally, a separate graph shows that the lemborexant group experienced a mean change of negative 20 minutes, so they fell asleep faster by 20 minutes by the end of the study, whereas the zolpidem group and the placebo group ended around negative 8 minutes. The same graph also looks at a change in sleep efficiency of each group, which is the total amount of time of sleep compared to the total amount of time in bed. And again, the lemborexant 10 milligram group showed increased changes compared to the rest of the groups. The graph also looks at WASO, or wake after sleep onset, which describes how long an individual is awake from the time that they essentially the lights out until their supposed wake up time. Now, the larger the negative value, the more impact it had. And again, the lemborexant groups showed increased values compared to the other groups, indicating that they had better sleep maintenance and better sleep onset. The larger the negative value, the bigger change that they experienced with that. And it showed that the lemborexant group indicated better sleep maintenance, or being able to sleep throughout the night, not just falling asleep faster. Overall, this study showed that lemborexant therapy was effective in improving both sleep onset, falling asleep, and sleep maintenance, staying asleep. And these improvements were both observed initially as well as throughout the study. This research shows a promising option for those that are currently or will eventually suffer from insomnia disorder.
And thank you very much for all of that, Nathan. It's really interesting to hear both the medicinal and the non-medicinal, as you started with, sides and different avenues that we can take to start to address and combat insomnia for those of us suffering with it. So as we start to wind down our episode, let's briefly review what all we discussed. So we started with Ben. We looked at ways that chronic insomnia might start to arise for us and some of those different causes. We then went over to Anna and we discussed some of those different methods that we can use to start to detect insomnia clinically, whether that be with the EEGs or other methods. I interjected myself and included some information about how EEGs of the past have not always been aware of that region by region sleep basis. And then we ended with you, Nathan, with some of those treatments, both medicinal and non-medicinal, in ways that we can start to combat insomnia. So I thank you, all three of you, for being here, and I appreciate your contributions.
Yeah, thank you
Thanks for
again.
having us.
I hope you found this time to be valuable and informative for you as you seek to expand your knowledge of neurobiology. Thank you for your time and interest, and we look forward to sharing more practical neuroscience information very soon. Thank you.